When you join the lovely MS community, or if you're just learning about this amazing community, of course, I'm biased. It's important to remember that there is huge variety in how MS presents and in how the disease progresses. So, just because your aunt was diagnosed with MS and she's fine, or it hardly disabled her at all, that's not going to be the story for everyone with MS. And that's just something that is really important to keep in mind. I think of MS in three kind of basic chunks of categories. You have the isolated syndromes, then you have the relapsing remitting, and then you have progressive. And there are kind of two main subtypes for each. So I'm going to break down each of these subtypes for you in this video so you have a more general understanding of the breadth of variety that comes with this diagnosis. And it also explains why, when you meet someone with MS, you've just met one person with MS, and someone else's MS journey will look completely different. At the very beginning of the MS journey, you might be diagnosed with CIS, clinically isolated syndrome, or RIS, which is radiologically isolated syndrome. For me, I was first diagnosed with CIS, clinically isolated syndrome. This is really the first instance where someone can pinpoint an event where they start having the MS-like symptoms that isn't really explained by anything else. Sometimes, but not always, you'll see on their MRI lesions or areas of damage in the brain or spinal cord. If you're diagnosed with CIS, you may or may not go on to develop MS. For some people, the CIS is the only event and it doesn't happen again. So for me, initially, I thought I had flared up an old elbow injury where the elbow, the bones of the elbow, compressed the ulnar nerve that runs through the elbow. And when that nerve gets compressed, it causes weird, numbness and tingling in your hands. I was referred to a neurologist to do some testing on my left arm just to see exactly where the nerve compression was and how serious it was, to determine, since this was a pre-existing injury, if I would need surgical intervention, or if doing another round of splinting would be fine if I just aggravated an old injury. The problem was that when I got to that appointment and the doctor was doing the testing, he actually couldn't find any compression at my ulnar nerve, which is strange. So he did some additional testing, and my results were a little strange, we'll say, and he felt that I should go on for more testing, which included an MRI. Now, the MRI study showed that I actually had lesions on my cervical spine. So at this point, I'm diagnosed with CIS. They start me on steroid treatment, and I'm referred to a neurologist specializing in MS to do further testing. I had my CIS diagnosis for about 6 months before I went on to have another relapse where I had additional symptoms, and the MRI showed that I had additional lesions in my brain. Again, some people may get diagnosed with CIS and not go on to get an MS diagnosis. This may be because it was just a fluke of the immune system. We don't know why it flared up, but then settled back down and things are fine. But most of the time, when you have a CIS, a good neurologist will talk to you about the pros and cons of starting a disease modifying therapy or a disease modifying drug, because in some people, getting on this medication early at the first sign of a CIS can prevent them from going into MS, which is great. And for a lot of us, getting on that medication early slows down the progression or the rate at which your MS relapses, and also the severity of each relapse. So it's still important to have those conversations about kind of what's going on with your body, your circumstances, and if going on to a specific medication would be beneficial in your case. Now, the second group in this camp of the isolated syndromes is the radiologically isolated syndrome. For this person, they have MS like lesions on the brain and spinal cord, but they don't report any symptoms. So they're not really like noticing the damage that's happening in the body, or where the damage is, or the extent of the damage isn't enough to kind of like come to the surface and be noticeable. My guess and how they find this is maybe the person is in a car accident or some other type of accident, or they get injured in some other instance where maybe they need an MRI for something. I'm from America, so I can't imagine anyone just like being able to go get an MRI for funsies, but you're getting an MRI for something else, and they just so happen to find that there are lesions on your spine and brain that are consistent with MS or very similar to MS, but you're not getting any symptoms. Again, in this case, this person may or may not go on to develop MS. And again, you need to talk to your neurology team about like what is the best course of action given your specific medical circumstances. So CIS and RIS are typically like the first stage in the process of diagnosis. There isn't like a specific blood test or one specific test that says, oh, we tested you, you tested positive for MS. You get a lot of testing done over a long period of time. And part of your diagnosis is kind of seeing these patterns of relapse, remission, or progression, and seeing how kind of the disease plays out in your body and your circumstances. And they will do a ton of testing to rule out other conditions that could be causing similar things to be going on in the body. Now, you might skip being diagnosed with CIS or RIS if, for example, you've been having symptoms for a while and they were attributed to another condition, another disease. But as your condition progresses, it actually fits better with an MS diagnosis. And so maybe you were initially misdiagnosed initially. And so the neurologist may have enough medical history or information there to like skip that CIS. They might say, oh, actually, these times you went to the doctor, those actually were probably all relapses or progression. And again, that is determined by your neurologist based on your medical history. So it is possible to get, a straight up MS diagnosis before not going through that CIS or RIS stage. With MS, the earlier you start treatment, the better the overall outcome is. In some people, again, disease modifying drugs can stop it at the CIS or RIS stage and not go on to develop any further lesions or any further disability. Okay, so you've been diagnosed with MS. And our two next big categories are the kind of relapsing remitting type and the progressive type. RRMS, or relapsing remitting MS, is the type of MS that I think most people are familiar with. In relapsing remitting MS, you have distinct events of like disability, flare up, immune system attacks, and then a period of remission where you recover partially or completely from those symptoms. Typically, how this is explained is that disability shouldn't progress or get worse between those flare ups or relapses. I currently have a diagnosis of relapsing remitting MS where I gain back some of the function that I lose during a relapse. For example, in my most recent relapse, I was unable to stand or walk during my relapse. When I was hospitalized, I could barely lift my right leg, and my left leg was just kind of like dead weight that I had to move around with my hands to help with transfers. MS doesn't just affect the muscles. During this relapse, I also lost control of my bowels. After a lot of treatment, physiotherapy, exercise, I have my bowel control back, yay. And I'm able to walk short distances using my forearm crutches and am learning to use a wheelchair for longer distances. It's important to know that the Symptoms or the effect of the disability fluctuates based on how the environment impacts the nervous system. So, for everyone, heat impacts how the nervous system functions to a degree. And if you have a healthy, whole nervous system, you probably don't really notice the changes that your nervous system goes through if it's hotter. For me, when it's hotter out or there are other things impacting my nervous system, like maybe I'm sick, maybe I'm not well hydrated, I'm tired, the environment is really busy. My nerves have trouble sending messages that are clear. And so some of my old symptoms will start to flare up or come back again. So, for example, if I'm in a really busy environment, I actually can't walk. Like I can tell that the tone, the spasticity that started to get better after the relapse actually starts to get worse again until I'm in a calmer environment. So you have kind of this day to day fluctuation in your level of disability and function. So there are certainly good days where I maybe have more energy, things are running more smoothly, and I don't need to use the wheelchair as much, or I can walk a longer distance on my forearm crutches. But then there are days where I'm kind of almost back at that relapse stage where I really can't walk. Okay, so as a summary, there was a distinct event. I remember the day, the time, the moment that my legs just checked out on me. So that's a distinct relapse event. And then there was a period of time where I've regained some of that function back. I just want to share a quick note on relapses. Scientists don't really know what causes a relapse. So, in a relapse, the immune system starts to attack the myelin around the nerves. And sometimes these attacks can actually cause the nerve cell itself to die, in which case the damage is more permanent. And there's thinking that it could be a little different for every person. There's interesting research going on in infection, and maybe that triggers the immune attack, but maybe it's stress. So scientists aren't really sure why the body does this yet. I do want to note that scientists have done a lot of research on MS and vaccines, and the research shows that there is no link between getting vaccinated and getting multiple sclerosis. The one thing that you do need to remember, though, is if you're on an immune suppressing drug, like for example, I'm on an immune suppressing drug to try and keep my immune system calm, that will dictate at what time of the month you can get your vaccines or like how you need to schedule your vaccines so that the vaccine can be most effective. So if I take my immune suppressant and then I get my vaccine, the body's not going to be able to build the antibodies and respond to the vaccine like it's supposed to. So it's like getting the jab for not much benefit. But on my particular medication, if I wait 2 weeks, then my immune system can build enough antibodies to make it so that the vaccine works for me. And I get the best of both worlds where I'm on my immune suppressant for my MS, but the vaccine is able to do its job and protect me against things like flu and COVID. And that is a really important conversation to have with your care team. I've been on other MS medications where it didn't matter. I could have my vaccines whenever. It didn't matter when I took my medication. So it's just something to be aware of, but there's no evidence, like there's tons of research that shows that there's no link between vaccines causing MS or vaccines making like an MS relapse happen. Okay, so the second type of relapsing remitting MS is called benign MS, which is a totally crap name for MS because the word benign means not harmful. And literally anyone who's diagnosed with MS has been harmed. So MS can't be benign. But that's what some person has named it, and that's what we shall call it. In this case, someone will have these periods of relapses and they'll get total recovery. So, for example, they might have a mild relapse and they maybe like lose sensation, or maybe they lose bladder control or something like that. So, there's been an MS relapse And then after that relapse, they gain back everything as if the relapse didn't happen, which is probably the worst way of putting that because you're not going to forget a relapse. They're scary. But all that to say is they gain back 100% of what they lost, and the body kind of goes back to that normal baseline. Then for them, typically they get like 10, 15 years before another relapse hits, and then they regain all their function. I think sometimes there can be confusion as to why are there people whose MS kind of hits and then that person gains back all their function. I want to be clear that these people aren't doing anything special or different that makes their MS less disabling than those of us who have a relapsing remitting type in which our body does not completely recover. And sometimes when this happens, someone will attribute this benign form of MS where they relapsed and then they gain everything back to a specific diet or exercise program to like curing their MS. But there's actually no evidence that this is the case. It's just, and we're not trying to get into the disability Olympics, but they just have a milder form of the condition, or for whatever reason, when these flares happen, something about their immune function actually is working correctly that can kind of help stop the runaway train before irreparable damage is caused. Or they have some kind of unique ability in their own genetics to maybe repair better. We don't know what that is, but it's not like an outside thing that they've been able to do. It's something unique to their MS journey. And it can be really easy to compare yourself to them and think, like, why isn't my MS progressing that way? Like, why is mine hitting me like a train each relapse and I'm only getting so much back? Like, you're not doing anything wrong. You're not doing MS wrong. There there's just so much unknown and variability, and that's kind of just it's the hard thing about this condition. It's also important that a person has benign MS until it's not benign anymore. For some people, that first incident, that CIS, or those first couple of relapses where they completely recovered, maybe they do go that 10 years, and then they might have another relapse that isn't benign, and their body isn't able to fully repair, fully recover, or it does a lot of damage during that relapse. And when we associate our actions like exercise, diet, certain things with whether or not we're having a relapse, we really are setting ourselves up for some massive trauma when this relapse comes and kind of wallops us out of nowhere, because having a relapse is never your fault and it's never anything you did to cause it to happen to you. So I do personally have a bit of a problem anytime someone says something cured their MS, because that means if you have another relapse or flare up or a worsening of your condition, then you're to blame, or you're going to blame yourself when your MS worsens. And that is not a healthy headspace to be in. The problem with saying that someone cured their benign MS means that you're also going to be blaming them when that MS turns incredibly harmful, or they have another relapse, or for some reason their body is no longer responding in a benign way. And that's not a healthy headspace to get into when we're talking about this lifelong disease where it is stressful and there's a lot of emotional things that happen in having to deal with such a chronic and fluctuating condition, that creating this story that we can like control our MS while like maybe feels comforting in the moment actually can set you up to feeling quite awful about yourself as your disease progresses. So if you're really struggling with that, I spent a lot of time getting mental health care around my diagnosis and kind of what I was going through. So reach out and get the support that you need so that you can realize that a crappy thing is happening to you. You're not the cause of that. So at the end of the day, there are things that we can do to manage, to mitigate, to kind of like help ourselves out as best we can. But we ultimately don't have control over how our MS journey is going to ultimately progress. Okay, so that was a lot. All right, now we're to that final category of the progressive MS. Some people with relapsing remitting MS will go on to develop secondary progressive MS. Secondary progressive MS is typically diagnosed after you've had a history of relapsing remitting MS. And at a certain point, that relapsing remitting MS stops being more relapsing remitting and starts being more progressively, slowly, day by day. You're losing function and you don't have those periods of remission where you're gaining back skills and you're coming to a new baseline. Typically, this is kind of measured over a 6-month period where your disability is getting worse and worse. But again, you're not having those distinct episodes where you're like, well, I could walk, but now I can't on the same day. But it's more like, oh, over the last 6 months, 6 months ago was able to do a standing transfer, but now I 6 months later can't stand up from my wheelchair to help with transfers. So think about again my experience of relapsing remitting MS. There was a date, a time in the morning when my body went from like working to not working. I remember that. I can pinpoint that time, that moment where it hit me. In secondary progressive MS, you might notice that over a course of a few months or years, you lose the ability to walk without being able to point out like a distinct moment in time that happened. Before disease modifying therapies or drugs, the average time it took for someone to progress from relapsing remitting MS to secondary progressive MS was about 20 years. Now, today, someone with relapsing remitting MS may or may not go on to develop secondary progressive MS. We don't know why some people progress to this stage and others don't. I also want to point out that it's not cut and dry telling the difference between relapsing remitting MS and secondary progressive MS. While you're not technically supposed to have progressive disability between relapses in relapsing remitting MS, we're actually finding that many do have disability progression during the like remission stage of things. So in my case, what I noticed is that my fatigue, my weakness, and my bowel and bladder control were like very slowly worsening over time, despite not having like a relapse event that I could point to. People with secondary progressive MS can sometimes pinpoint moments or times when they notice, like on this day, it definitely got worse, or in this like short period of time, it definitely got worse. And they noticed that, and they didn't really have that remission phase. It's like things got noticeably worse, then slowly worse and worse and worse. And then maybe they have like another little relapse where oh, I'm noticing that's getting worse. And so there's a lot of gray area in RRMS and secondary progressive. So in kind of turning that corner in that diagnosis, it really does take time to kind of see how your MS is playing out. Right now, for me, my pattern is a big relapse followed by like gaining 60 to 70% of my function back from kind of that worst point in my relapse. Even though my disability is progressing, I'm still technically in that relapsing remitting camp because I do gain back some function after my relapses. If one day I'm not able to gain back that function, or I go like a really long period of time where I'm just getting worse and worse and worse, then that might be a time where my neurologist and I discuss if I've progressed to secondary progressive MS or if I'm still technically in the relapsing remitting side of things. So that's why it's always important to speak with your neurologist about your pattern of symptoms and the different treatment options available to you. And then we have primary progressive MS. Someone who has primary progressive MS will be diagnosed with this from the beginning. This person will have MS like symptoms that will progressively worsen over at least the course of a year. And they don't go through distinct periods or stages where they have this like relapse remission. It's kind of like their immune system skipped straight on to the progressive stage of things. Now, they may experience times where they've kind of had symptoms worsening and their disability has increased, and then they plateau and they don't have worsening symptoms, but then hit another period where they will progressively get worse and they don't have that like remission phase where things get better. Now, this type affects 10 to 15% of people who are diagnosed with MS and is usually first diagnosed when someone is in their 40s. Of course, I'm talking in averages. So, with the variability in MS, you might see, outliers with these numbers, but these are our averages. The thing about primary progressive MS is that typically there's like little or no inflammation that shows up on the MRI, and scientists are still trying to work this one out. So, again, while I don't like to necessarily generalize because there's a lot of nuance, it can be helpful to think of MS in three distinct categories with two types of MS in each category. So pre MS has CIS and RIS. Then we have relapsing remitting MS, which has your relapsing remitting type MS and your benign MS. And then we have the two types of progressive MS, which is secondary progressive and primary progressive. While this framework can help us understand MS in general, again, it's always important to remember that there's a lot of variability and overlap within these really broad categories. It can be helpful to track your symptoms, notice your patterns of relapse remission or progression to get a better understanding of how MS is playing out in your body and to highlight any changes to your neurologist or MS nurse. So, what's your pattern of MS? Leave a comment below and subscribe to help other people find this content. Thanks for watching, and I look forward to seeing you again soon. Oops. Yeah, great. I'm trying to set up mic stuff.